what we have discussed up till now, and also in the second half of it. So this was our patient, Pretty Priya, who had come to you with complaints of fever, headache, throat pain. She had been partially treated for tonsopharyngitis, and unfortunately treatment was not taken complete because the investigation was not done properly, and periodically she used to take antibiotics, paracetamol, some anti-allergics, and she continued to suffer recurrent throat infections because she had just attained the age where she was started going to the school. So it happens primarily in the school going children. And if you do, okay, I had given you a task. Did you people examine the throats of people in your family? Did you get familiar with the anatomical landmarks, the uvula, the pharynx, the posterior pharyngeal wall, the tonsils, the arches, the folds which hold the tonsils? You must all get familiar with that, so that you don't miss out this glaring finding of involvement of tonsils whenever you are talking about any pharyngitis. Pharyngitis with tonsillitis is tonsillopharyngitis, commonest cause of group A beta hemolytic streptococcal infection. So she kept on getting recurrent attacks, and then it led to what we call as the immunological sequelae. So from infection, it moved on to immunological sequelae. Why this happens is because when the bacteria get into the body, it produces certain antigens which are identified by our body as foreign antigens, and it stimulates the acquired immune system, both the B cell as well as the T cell. So there is antibody production after identification of the antigen as foreign antigen. It is processed either with MHC1 or MHC2 molecule. It can lead to both cellular as well as humoral immunity with the production of antibodies, with the production of T cells, and most importantly, production of memory cells which will keep the memory of that particular exposure to the antigen, so that on subsequent exposure, the body produces the antibodies much more quickly and much more strongly. So Pretty Priya suffered from manifestations of knee, anorexia, ankle, the on and off fever with involvement of the respiratory tract or cardiovascular system. Okay, that takes us back to, I had requested you all to start handling your stethoscopes. So please start examining chest, heart sounds, even abdomen, listening to the intestinal sounds through the stethoscope. You can do wonderful things with stethoscope if you are observant enough and if you are analytical enough to identify and analyze the types of sounds which you can hear through stethoscope. So get familiar with stethoscope. It's one of the most important tools with doctors for clinical examination. So we found what is acute rheumatic fever and what could be consequences. So it's an immunological sequelae which involves multiple systems, and it can keep on occurring on and off because of the recurrent infection and recurrent stimulation of the immune system by the antigens of streptococci. Commoner in female, younger children, and some of the strains of streptococci are more associated with this than other strains, as well as there is some genetic and familial predisposition. The pathology is that the M proteins stimulate the acquired immune system, stimulation of the both antibodies production as well as the T cell, and therefore those antibodies and the T cells identify our own antigens as foreign antigens, and depending on the site of those antigens, involvement could be of the joints, cardiac valves, skin, or myocardium. The proliferative and exudative changes of inflammation occur, which can lead to scarring and which can lead to subsequent damage to the structures. So we have seen what were the features in the joints. Primarily the bigger joints get involved, and these are migratory arthritis. That means it moves, shifts from one joint to another joint. This would be the clinical examination. Inflamed red tender Penn's joint. There could be skin manifestations, uncommon in Asians, but one can see the marginal erythema marginatum. Therefore, you must examine the patient thoroughly, even if the symptoms are not there pertaining to that system. Patient may not notice those symptoms, but you can identify some of the signs. Like the subcutaneous nodules, painless, are not noticed, but they have got prognostic significance. And some patients may be reported with poor handwriting, particularly children, and that can occur because of what we know as a neurological involvement leading to chorea, which are involuntary, purposeless movements of the limbs. It could be one-sided or generalized. Luckily, all these symptoms, all these signs, the cutaneous, the joint, as well as neurological, are transient and they get over within about 2 to 6 weeks time, and patient may not have any problem. But the problem actually comes because of the long lasting effects on the heart. So let's look at what happens to the heart in case of rheumatic disease. That is now called as rheumatic heart disease. So we are progressing from rheumatic fever or rheumatic disease into next sequelae, and the sequelae is involvement of the heart, various parts of the heart, the pericardium, the myocardium, as well as the endocardium and the valve. So one can say that all layers of the heart can get involved in rheumatic heart disease. The pathology is same. I'm sure pathologists must have shown slides about these, that there is a proliferative change, there is an exudative change with perivascular inflammation, like it happens in the joints, heart and brain. The difference is that these changes, inflammatory changes, disappear without leaving any scars in the joints and brain. But unfortunately, the myocardium and endocardium gets damaged much more, and there is more scarring in the tissue, which leads to structural changes, which lead to functional changes of the heart. The joint, when it is inflamed, can be rested, but heart cannot take rest. It has to work 24/7, and that is perhaps one of the reasons that the inflammatory changes lead to scarring more often in the heart. There could be pericardial and pleural effusion also, but luckily the pleural spaces effusion disappears quickly. Pericardial effusion also can disappear quickly without leaving much problem, except sometimes there occurs fibrinous deposits and it can lead to adhesions between the pericardial layers. In the myocardium, there could be Aschoff nodule formation. Pathologists would have shown you great detail about that. So let's just recapitulate. The group A beta hemolytic streptococcal infection leads to antigen production, leads to antibody production, leads to immunological reaction, and sequelae becomes initial rheumatic fever. When there is a recurrence of the infection, it can keep on stimulating more and more antibody formation, which can keep on occurring as a recurrence of rheumatic fever. And this recurrent rheumatic fever is what can lead to rheumatic heart disease, because there is a prolonged, repeated damage and injury occurring onto the heart. 50% of the patients which get rheumatic fever will give you a definite history of preceding sore throat. But imagine, remaining 50%, there may not be a definite history of sore throat due to group A streptococcus. Now, how this someone could link this particular thing with this streptococcal infection was because of the epidemics which occurred with of throat infection epidemics occurring or outbreaks occurring in the schools, and after a few months and years, number of children from the same group presenting with rheumatic fever and rheumatic disease. They also did immunological studies and found that about 90 to 100% of the patients who suffer from rheumatic fever have anti-streptococcal antibodies. And then they check that these antibodies cross-react with the human heart tissue. So if there is higher percentage of antibody, if there is higher titer of antibody, there is higher chances of its reaction with the heart tissue. Someone did a very interesting study. They stopped the recurrent infection by administration of penicillin, either as prophylaxis or as a treatment, and then they realized that there are less chances of anti-streptococcal antibody formation and there is less incidence of rheumatic disease and rheumatic heart disease. So in developed countries, the incidence of rheumatic disease and rheumatic heart disease is extremely low. A common doctor, a general practitioner in Western society, perhaps sees only one case in lifetime. One case of rheumatic fever or maybe one case of rheumatic heart disease if he is lucky in his lifetime of 30-40 years of work. But in our country, you are likely to see at least 4 or 5 cases of rheumatic fever and rheumatic heart disease every month. So what they see in one lifetime, we see 4 times of that every month. That is because in our countries, even now, group A streptococcal outbreaks are very, very common because they are not diagnosed properly and they are not treated adequately. So our concentration should be on making sure that we identify the group A streptococcal infections in the children as early as possible and treat it adequately to prevent further occurrence of complications. If you treat the patients properly, the transmission of the bacteria also reduces. So less number of children will be involved. So each properly treated case actually prevents 4 or 5 more patients from getting this disease. So penicillin treatment for streptococcal infection is very, very important and it is affordable. So just to recapitulate, Streptococcus entering into the throat, getting picked up by our macrophages, antigen being processed either on MHC1 or MHC2 molecules, and those antigens being identified as foreign antigens, leading to stimulation of both B cells as well as T cells. And effect of that is production of the antibodies and its influence both on various tissues. We are concerned over here primarily if heart. So on the myocardial cells, it can lead to myocarditis. It can affect the valve. It can lead to valvulitis. Repeated infection, repeated antigenic exposure, more antibodies, more inflammation. It can lead to chronic rheumatic heart disease. And chronic rheumatic heart disease can cause pericarditis with effusion and then adhesions over there, which can lead to inhibiting the expansion of the heart. Okay, so that brings you to one clinical condition. You have to name the clinical condition where because of the pericarditis and the fibrin deposit over there, the pericardium does not allow the heart to expand and contract properly. What does it lead to? So that's a physiological condition or pathological condition which leads to impaired function of the heart. So you have to find out what is the name for that condition where there is surrounding the heart, there is pericardial thickening, fibrosis, which prevents cardiac expansion. The heart valves get damaged and the damaged valves, whether it is tricuspid, aortic or mitral, all these valves become predisposed to certain conditions. One is structural damage. It can lead to aortic or mitral valve incompetence, or it can lead to stenosis. Stenosis means narrowing of the opening, and incompetence means inability to close properly. So structural damage can lead to both stenosis as well as incompetence, that is the structural damage. But because of the damage to the valves, they can also become the places where the bacteria can go and get lodged and can lead to bacterial endocarditis. We'll talk about bacterial endocarditis in the subsequent classes, but remember that rheumatic heart disease leading to damage of the valves, leading to structural damage of the wall, is the one which is the most important predisposing factor for bacterial endocarditis. So rheumatic disease can cause pericarditis, endocarditis, myocarditis as well. Ash of bodies formation, I'm sure pathologists must have told you in detail. Just to take you through, these are the myocardial muscles, and this is the blood vessel, which is a normal tissue. And when there is an effusion, inflammation, and there is exudation around it, it pushes the muscles, and this exudation occurs over there. Over a period of time, there is proliferation and constriction, and then fibrosis, which can lead to narrowing of the blood vessel or obliteration of the blood vessels, and chronic inflammatory process or a granuloma formation, which is characterized by Anish-Koff cells and Ashkoff cells. If you find Ashkoff cells and Anish-Koff cells in a biopsy of the myocardium, it shows what changes have occurred over there, and these are indicative of rheumatic disease. So this is Aschoff nodule, normal myocardium, and disturbed myocardium is being replaced by the fibrous tissue, and these are the multicellular, multinucleated giant cells and the nodule formation, which undergoes fibrosis and leads to structural damage and loss of function of the myocardium in this region. So if this myocardium is replaced by fibrous tissue, that means the contractile property of the myocardium is reduced. Contractile capacity of the myocardium is reduced. So the ability to pump the blood also is reduced. Also, because of fibrosis, there cannot be expansion. So the volume of the ventricle or the atrium also gets reduced. Now let's have a look at the endocardium. During normal condition, the endocardium is very smoothly lined with the endothelial cells, which has got electrical charge, and it does not allow the blood cells to clump or get attached to them. So everything flows very smoothly. But what happens is that when there is inflammation, there is a swelling. You can see the increase in the thickness of this particular thing, and there is deposition of the fibrinoid degeneration, the lymphocytes, the polymorphonuclear cells, the plasma cells, and so many things come along with the inflammation, and then there leads to be fibrinoid degeneration and leads to scarring. This scarring causes contraction of the superficial layer of the endothelium, so the endothelium becomes rough or corrugated. Like you see chana, corrugated sheets, so this becomes corrugated. Now, this is an uneven surface, so blood cannot flow very smoothly over it. Also, here the structural strength gets less, so there is a bulging out of this endothelium, and some of the things like a ballooning up occurs, which over a period of time undergoes fibrosis and is pulled back. So what we are left with is an unevenly lined endothelial surface, irregular, rough, corrugated endothelial surface, which becomes the site for attachment of the bacteria or other cells. Also, since it has become irregular, it cannot perform its function properly. So this is what happens in the valvular lesion because of this fibrosis. It pulls the endothelium and the top layers inside. Because of endocarditis in the left ventricle, the mitral and the aortic walls get roughened, they get rolled up, they get edematous, and so they do not come, the valvular edges do not come close to each other to close when the valve should close. So it remains slightly open because they have become rough. Instead of being smooth like this, they have become rough like this. It does not close properly, it does not touch properly. And that leads to what is called as defect in the flow of heart, or flow of blood through the heart. Either it can lead to incompetence or it can lead to form non-expandable, non-openable valves. So it can lead to stenosis or it can lead to incompetence. Also, the papillary muscles also are inflamed, and instead of being normally big like this, they get shortened. So if they are shortened, they do not allow the valves to come in contact with each other. So that also adds to stenosis and improper closure, leading to regurgitation. Myocarditis leads to scarring in the myocardium. So the capacity of the myocardium to pump blood also decreases. The pericarditis does not allow the heart to expand properly, and therefore overall functioning of the heart gets reduced. Here is the valve. You can see this is the rough edges of the valve, and it is not able to close properly. So there is an incompetence over here. If you look at these chordae tendineae, they are shortened. So these valve cusps cannot come in contact with each other when there is a closure of the valve is required. So it can lead to stenosis or it can lead to incompetence. Now, when the blood flow through the heart is impaired or is leading to turbulence over there, it leads to production of the sound that is called the murmur. So what you hear with the stethoscope are the sounds which are produced because of the turbulence of the blood flow through the various chambers of the heart while passing through the valves. The turbulence occurs while the blood is passing through the valve, and that is the time when the murmur is produced. So murmurs are heard because of the turbulence. Also, there would be inflammation, so there could be pain in that region, which is mentioned as precordial pain because it's in the area right in front of the heart. Since the ejection factors is affected, the heart is not able to pump out the blood adequately, the capacity of the heart reduces, so it can lead to chronic congestive failure. It could be left-sided failure, or it could be right-sided failure, or it could lead to biventricular cardiac failure. How do you diagnose rheumatic fever and how do you diagnose rheumatic heart disease? Based on clinical features and based on laboratory findings, Jones criteria has been devised. Jones was a great scientist who has discovered these or have identified these things, and therefore we have got major criteria and minor criteria. Major criteria shows involvement of the joints, involvement of the heart, involvement of the skin. So these are the areas. If there is involvement of any one of these three, it is called as a major criteria. Minor criteria is again involvement of the joint, but it is only as pain and not as arthritis. So the signs of arthritis are not there, but the patient complains of arthralgia or pain. Patient may have fever, and then the laboratory investigations may show raised ESR or C-reactive proteins. As we discussed, ECGs will show prolonged PR interval because there is a conduction of the electrical current is affected, and as a mark of inflammation, we can see leukocytosis. So these are the minor criteria and these are the major criteria. There is some supportive evidence like the detection of ASO antibody titer or anti-DNase antibody or anti-hyaluronidase antibodies. These antibodies are produced against the antigens of the streptococcus. Why it is called supportive evidence is because by itself they do not give a diagnosis of rheumatic disease, because they only show that body is in a position to produce antibodies against various antigens of streptococcus. But whether these antibodies are going and attacking the normal tissue of the body or not, the laboratory cannot say just by titer. But that effect is seen when we see the major criteria or minor criteria of rheumatic fever. So, presence of antibody titers does not diagnose rheumatic fever. One has to have clinical minor or major criteria for diagnosis of rheumatic fever. All patients may not exhibit all types of symptoms and signs. Some may have only joint pain, some may have only joint inflammation, some may have cardiac involvement, some may not have cardiac involvement. So based on which features are present or not present, a combination has been devised that to diagnose rheumatic disease, one must have at least two major criteria, or there should be at least one major criteria along with two minor criteria. So this combination is very important. Based on only one major criteria or one minor criteria, one cannot diagnose rheumatic disease. And these major or minor criteria should be supported by the supportive evidence of antibodies against streptococcus. This is also equally important. This shows that whatever these major and minor criteria have occurred are most probably because of the antibodies against streptococcus. If antibodies are not present, even with major or minor criteria is present, we cannot say that it is because of streptococcus. It could be because of something else. That's also possible. Doppler studies, echocardiography, etc. are primarily to see how much of the heart function is normal and how much of the heart function is affected. So these are important from prognostic point of view. So diagnostic point of view, major and minor criteria, supportive evidence. Prognostic point of view, Doppler and echocardiography studies, so that we can manage and prevent cardiac failure and other further complications. So this is from one of the books about rheumatic disease, Jones criteria. We should have major and minor criteria combination to give it a diagnosis of rheumatic heart disease. How to make it easy to remember? If you can remember the name Jones, then each letter of the name indicates one particular criteria. J for joints, that means patient should have polyarthritis. O for heart or carditis. N for nodules, that is skin manifestation. E for erythema marginatum, again skin manifestation. Be sure that in Asian population we don't see erythema marginatum that often. And S is Sydenham's chorea. So it is Jones is a complete name, not an apostrophe S. So Jones criteria by joint, heart, nodules, erythema, and Sydenham's chorea. So if you can remember this mnemonic, you can very easily diagnose a patient of rheumatic disease. But Jones is not an Asian name. It's not an Indian name. It's not a Nepalese name. So sometimes you might be confused to remember this name. So we have devised something else, something which all teenagers go through. What is common amongst most of the teenagers? What is common topic of discussion amongst most of the teenagers? Something about which almost every teenager is very highly concerned. Those who get it are concerned, and those who don't get it also are concerned. Those who get it are concerned because their looks may get affected. They may not get too many boyfriends or too many girlfriends. And those who do not get affected are also concerned because they don't have a topic to talk about. Any guess as to what is that? What is there very high on the minds of teenagers?
Acne.
Yes, anyone? You can you repeat, please?
Acne. Pimples.
Acne, yes. Yes, pimples. Those who get pimples are worried that their looks are bit not that attractive, and those who don't get don't have things to talk about because acne leads to lots of discussion. What moisturizer one should use, what cream one should use, what soap one should use, what one should avoid. Should they avoid spicy food? Should they avoid this, that, and so many thousand and one things? None of them actually influence acne. These are all gimmicks to sell various soaps and lotions and moisturizers and things like that. The acne is primarily dependent on your hormonal status. With the changes in hormones, it will happen. With the changes in hormonal status, it will disappear. Some people may have more acne, some people may have less acne. Lesser you think about it, lesser the chance of getting acne. More you think about it, the stress by itself changes the hormonal levels and leads to more acne formation. So acne can be used also as an mnemonic: A for arthritis, C for carditis, N for nodule, E for erythema, and S for Sydenham's chorea. So you can remember any one of these mnemonic to be sure that you diagnose a patient of rheumatic heart disease very early. Very early diagnosis and proper treatment are most important. Once you have diagnosed, you need to treat the patient and treat the patient for one, infection, and two, for inflammation. Both treatments are entirely separate. So if you are getting a patient with rheumatic disease or rheumatic fever or rheumatic heart disease, first and foremost thing you need to do is to make sure that the patient is not suffering from reinfection. So pick up a throat swab, whether patient is a carrier or whether patient is suffering from acute pharyngitis. Pick up a throat swab, send it for culture. Make sure that all beta hemolytic streptococci are identified, preferably serotyped. And then if those serotypes belong to the which are likely to cause rheumatic disease, you need to treat the patient. And treatment for streptococcal infection is penicillin, preferably injectable penicillin, if not oral. But oral penicillin is not so effective because absorption is not very well. So therefore, treatment of reinfection is important. Treatment of reinfection of anyone who has got sore throat. So therefore, whenever a patient comes to you with sore throat, examine the throat properly to differentiate between whether it is a viral infection or a bacterial infection, whether there is tonsillar involvement or no tonsillar involvement. Send for gram stain and culture. If you find streptococcal infection, treat it. If the patient has developed arthritis, then the patient requires immunosuppression with aspirin and prednisolone. Aspirin is a wonder drug. It's a great drug because particularly in rheumatic joint pain, aspirin works like a magic. If you give adequate dose of aspirin, within few hours, the pain and the swelling of the joint will disappear. So it becomes a therapeutic test as well. So if you suspect clinically that there is a arthritis and it could be because of rheumatic disease, if you just give a dose of aspirin to the patient and after 6 hours you examine the patient again, patient will say pain is almost gone and you will find signs of inflammation also decreasing adequately. So that then you must continue with aspirin. So you need to find out what is the dose of aspirin in case of rheumatic disease. The dose of aspirin for headache, the dose of aspirin for other conditions are very different. The dose of aspirin for prevention of thrombus in the coronaries is very different from the dose of aspirin which is given for rheumatic disease. So your job next is what is the dose and duration of aspirin for the treatment of rheumatic disease. Find out that. And so is prednisolone. Both of these drugs suppress the immune response, and thereby limit the damage which can occur to the joint or to the heart. Therefore, if you diagnose early, you must institute an early immunosuppressive therapy, continue it for adequate time to make sure that chronic effects on the heart are prevented. If the patient is having any other symptoms or signs, you need to give the supportive treatment. Like for the pain in the joint must be kept immobilized. Patient should not move around. Patient should, if patient is having fever, maybe aspirin itself will reduce the fever to some extent. If patient has got any other features, you need to take care of them. And if the patient has developed cardiac symptoms, one has to treat the patient very carefully to make sure that cardiac ejection and perfusion is adequate and patient does not go into CCA. How do you prevent? Any child who complains of migratory polyarthritis and any child which can be clinically diagnosed as having rheumatic disease, penicillin prophylaxis is a must. The prophylaxis is preferably given by injectable long-acting penicillin, and it's given at a duration of about every 3 to 4 weeks. So we need to even find out as to how to give a penicillin prophylaxis to a child, because the child must visit you every month to get long-term penicillin prophylaxis. This is a job where the doctors have to emphasize very well onto the patient and patient's family that they must by date come for their penicillin injection. There is a tendency amongst patients to forget or to ignore treatment once the symptoms and signs start disappearing. So you give aspirin, patient joint pain goes away, you give one shot of penicillin, and then you tell patient to come after 3 to 4 weeks. Patient will not return because there is no more pain, there is no more problem. And patient says, why should I spend money and go and get another injection? Is the doctor trying to make money and fool me? So you need to educate the patient, educate that this penicillin is going to protect the heart from chronic effect of rheumatic disease, and if you don't take this penicillin injection, you are likely to land in much bigger trouble, not today, not tomorrow, but maybe after a few months or few years. So patient education is equally important for prophylaxis. How you can prevent? First and foremost is the school children need to be educated, and school children must be treated adequately to reduce the infection or to prevent transmission from one person to another. Luckily, because of COVID, these days everybody is wearing masks, and hopefully in the schools, even after the schools open after COVID, people will continue to follow using the mask in the school also, and also hand washing facilities. Therefore, we expect that not only COVID, but other respiratory infections also will reduce to a great extent. So mumps, measles, and streptococcal infection should reduce, and our country also should become, in another 10 years time, should become much more freer and reduce incidence of rheumatic disease. Certain individuals at high risk because of their genotypes or because of their exposure to the other students, other teachers, or other personnel who might be carrying streptococcal organism, and therefore they also need to be identified and guided accordingly to take precautions. The prophylactic antibiotic should continue at least for 5 years if the patient has been proved to have had rheumatic disease. Don't wait for patient to develop rheumatic heart disease to start prophylactic antibiotic. The first sign and symptom of rheumatic disease could be joint and skin. So as soon as you diagnose rheumatic disease, make sure that you put the patient on prophylactic antibiotic at least for 5 years. Sometimes it might be required lifelong to prevent extension of rheumatic disease into rheumatic heart disease, or for developing further extension of the rheumatic heart disease into further complications. So make sure that your patients take antibiotic regularly. Vaccines are said to be best way of prevention of most of the infectious diseases. Do we have a vaccine to prevent rheumatic disease? Can we have a vaccine to prevent rheumatic disease? What are your views? What are your thoughts about it? So assignment for you people over the weekend is, are there vaccines for prevention of rheumatic disease? If there are, name those vaccines and how do they act? If there are no vaccines, why do you think vaccines have not been prepared to prevent rheumatic disease? Any guess? Anyone? Are there vaccines or there are no vaccines? Will vaccines be useful? Will vaccines not be useful to prevent rheumatic disease? Can anyone tell us anything? Based on whatever pathogenesis you have studied so far? You want time to think or you want to say right now? You can unmute and respond. We have enough time. Can you unmute and respond whether there are vaccines or no vaccines, and can vaccine be useful or can vaccine not be useful to prevent rheumatic disease? Any takers? Okay, I give you time. So upload your answers by Sunday. Two more things which you need to study, which we are not covered in our classes, is Sydenham's chorea. What is Sydenham's chorea? In which age group it happens? What are its manifestations? Why it is called Sydenham's chorea? What is the basis pathology? And what is the outcome of Sydenham's chorea? So that's one thing you need to study. And second, ECG changes in rheumatic carditis, so that next time there is a child which suffers from any disease and you take an ECG and you have a look at ECG, you can diagnose whether patient has rheumatic disease or no rheumatic disease. I guess in physiology they must have told you about some of the changes in rheumatic disease. If they are not, check up from the books. There are very interesting information available on this. So what should you consult? There are many good books, textbooks of medicine, Harrison also, Manson's also, and other books also. There are lots of information available online also if you don't have access to the books. So look up into those informations and note down relevant points, note down answers to the questions which we have discussed or we have raised during these classes, so that you are prepared about rheumatic disease and rheumatic heart disease. I guess pathologists also have told you about this, so you should be having enough adequate knowledge about it. And in the next classes, we'll talk about what complications rheumatic heart disease can lead to. One and the most important complication is endocarditis. So we'll be talking about endocarditis in the next class. Would any one of you like to take the CME credits and get a certificate from maybe Medscape or BMJ? BMJ is British Medical Journal. Medscape is an American organization. So would you like to have some certificates for having studied something from these organizations? Are you interested? You may unmute
Yes,
and
sir.
let me know.
Yes,
Okay.
sir.
Okay. So what I will do is I'll upload some link where there is online learning material available and online questions also available. If you appear into that and you qualify that, you will be issued a certificate of completion of the CME activity. And please remember, even after you have graduated, the Nepal Medical Council and the medical councils in different parts of the world now require that every 5 years you will need to renew your license. And one of the conditions of renewing the license is making sure that you are continuing to learn. And that is done by continued medical education activities, which can be done online or it can be done by attending conferences and learning from the conferences. So sometimes you will have access to the conferences, sometimes you may not have an access to physical conference. In that situation, you can take online courses, you can take online certification, and you will be required to submit these online certificates for continuation of your license. So if you get into the habit of getting these credits at this stage itself, it will enhance your knowledge. It will also make you familiar with how you can take online courses and expand your horizon and get certification. So I'll share some of the links for that. I hope you make use of it and get your certification as well as improve your knowledge. So far, any questions about rheumatic disease and rheumatic heart disease? If you have any question, just unmute, and we have got some minutes to exchange, so we can exchange some knowledge, some information. Anyone? Any doubt? Any question? Okay, so one question from my side for you is about vaccines. Anything and everything about vaccine to prevent rheumatic disease. That's your assignment. Please submit that assignment by Sunday. The other questions also I have asked. If you read something about it, you note down something about it, please upload it so that we can share it and we can comment upon whether what you found out is right or not, or if any more questions come to your mind based on what you have read, please raise those questions. Everything is not yet understood about rheumatic disease. There are so many unanswered questions. You should be having more and more questions, queries, doubts in your mind. Feel free to ask them. We would be happy to help you in understanding it. If you know the answer, we would certainly like to share with you. If you do not know the answer, maybe jointly we can explore and see how you can get the answer to our questions. So that's all about rheumatic disease and rheumatic heart disease. If you have got no questions, no doubts, maybe we can take a break now because we will have next class in about 15 minutes time. No questions? Okay. Thank you. So we'll discontinue over here and we'll meet on next class is tomorrow, 6th at 11:15. Okay, see you. Stay safe, take care.
Thank you, sir.